I said before, when I did the introductions yesterday, that I don't have anything to do with planning the pain short course. That's the planning committee there. And this year, they asked me if I would be willing to do a debate with someone in the pain field that was more on the preclinical or more on the peripheral side of the pain mechanisms about whether peripheral or central factors were more important. And when they asked me to do that, I immediately thought, I don't really want it to be a debate, but someone that I've had a tremendous amount of respect for over the course of my career is Michael Gold. And I actually I don't know Michael that well. I got to know him a lot better in the last day or two than I have over the course of our careers. But in any time that I heard Michael speak over the last 15, 20 years, he is unusually good at following the entirety of the pain literature, even though he himself does preclinical work and does more basic science work. He follows what's going on in all of the literature, and that's really impressive because I don't similarly follow the preclinical literature, to be honest with you. It's just too hard for me to understand. I don't really get a lot of what's going on with respect to preclinical research because I don't do it. So, the first thing is this is starting with a sense of just mutual respect, is that he knows a tremendous amount about peripheral mechanisms. I know a fair amount about central mechanisms. And so what we're going to do is Michael will begin by giving about a 20-minute talk talking about peripheral mechanisms. I will give about a 20-minute talk talking about central mechanisms, and then we will sit down and talk to each other and ask each other questions, and we'll get the audience involved as well. But I know we did this accidentally on a phone call 3 or 4 weeks ago when we talked about what we might do, and it was just fun. It was just really fun as a scientist to have these kinds of discussions. And I think just in general, science doesn't have enough fora for these kinds of interactions and discussions and things like that. People have a tendency to stay in their little silos and work with people that they're comfortable working around. And so, again, I think this will be fun. I think it'll be informative, but it could go entirely off the track. So, Michael?
Thank you, and thanks to the organizing committee for putting this together. This has been fun. It's been fun even talking days ago or weeks ago, and I'm properly fatted, for the sort of lamb before the slaughter here. So, yeah. So peripheral. What I thought I'd do is start with some of the common ground issues, if I could. Nothing to disclose. So common ground. Hopefully this isn't something we're going to debate. Pain is in the brain. It does require cortical components that will hopefully result in the percept, or hopefully not, if we can block it. The brain can generate the percept of pain in the absence of peripheral input. I think the discussions that we had yesterday really highlighted that, or at least reminded us we don't have to be feeling, that is, experiencing a noxious stimulus to have the percept of pain. Our brains can generate it, and that's clear. I will concede, and I think this is an important starting point, that neural mechanisms have been described that would enable a chronic pain state to persist in the absence of peripheral input. I'm going to keep coming back to this notion, but I'm fully, I embrace the notion that changes in the spinal cord, the brainstem, in the brain can be such, or to such an extent, that normal sensory stimuli, normal input along our sensory pathways would be perceived as pain. And so I will completely acknowledge that exists. Even though I'm going to lay the groundwork for why I think the periphery is an important therapeutic target, I will completely acknowledge that we can help pain by targeting central targets. And I think there's a number of viable central targets to go after. I'm not sure you're going to buy this one, but I would also contend that despite everything I've just said, I would still contend that the vast majority of pain, even clinical pain experience, is still dependent on afferent input to the CNS. So that would be sort of the common ground. And then I'm just going to sort of make the case here for where at least the primary afferents are involved and where the data are. And it's going to be, for those of you that have been in the pain field for a while, it's going to be a sort of a trip down memory lane. For those of you who are new to it, hopefully you've at least read some of these papers, and so that it'll make some sense. So in terms of acute pain, this is just not an acute noxious stimulus. You stick a pin in your finger, you put your hand on a hot stove. That activity, it drives activity in sensory neurons that ultimately results in the percept of pain. So that activity correlates with pain reports. There are different subpopulations. Can you see the mouse here? No, you don't see the mouse here. Different subpopulations of afferents. This is just from a therapeutic perspective, what I think has been a hurdle for those of us targeting the peripheral nervous system for therapeutic endpoints, is that different subpopulations of afferents mediate different types of pain. And most problematically in the context of chronic pain, the evidence would suggest that those subpopulations probably change over time. And then finally, this is an experience that probably most of you have had. That is that if you block afferent activity, most commonly with local anesthetics, you can block pain. And I'm just going to give some quick examples of those. This is an experiment you can do at home. If you're wearing sandals and you just sort of want to stub your toe as you're walking into the house, generally what you're going to experience is that first sharp pain as you've, the initial input. It feels sharp. It feels, shooting, if you will. And then if you've hit it hard enough, to grab onto something because you're going to get this wave of pain that comes afterwards. And the difference between those two is actually due to the different conduction velocities of the neurons that are carrying that signal, where that first sharp pain is carried by A delta fibers that conduct a little bit more quickly, and that second, more slowly throbbing, burning pain that you really got to brace yourself for is carried by fibers that conduct with at a C fiber conduction velocity, or nerves that conduct at a C fiber conduction velocity. And you can take that even farther, where you can selectively block with a pressure cuff the A delta fibers, and you can eliminate that sort of sharp shooting pain, and you're left only with that throbbing pain if you're applying the same sort of stimulus. And you can do the converse with local anesthetics that are appropriately titrated. And we used to do this experiment. I didn't do it. It was Howard Fields, when I was at UCSF, would do this experiment in their pain course, just with a volunteer and blocking the different subpopulations of afferents. Old data, these are some data out of the Hopkins group, Mayer and Campbell, that were on the one hand reporting the human judgments, on the other these are activity that have been recorded in non-human primate neurons. These are C mechanoheat nociceptors, and they start with initial burst of activity and then will peter out. I guess that's shown here. You guys can't see what I'm looking at. Start with initial burst of activity, and then the activity decreases over time, and then these A mechanoheat nociceptors begin to fire. The human pain judgments are relatively constant. This is to a heat stimulus, but these two subpopulations of fibers are contributing. This is just an example of different subpopulations of afferents in a relatively short time scale that are mediating or differentially contributing to the percept of pain. And then finally, as I was saying, the classic example that many of you have experienced is that if you block afferent activity, you can certainly block the perceptive pain. Certainly in a number of contexts, this has been illustrated. Dentistry, if anybody's had a procedure where you actually needed a local anesthetic to enable the dentist to do what they do, hopefully you got the benefit of the local anesthetic. These are just some old data that we collected when I was still at the University of Maryland. And these are control subjects that were just having a tooth extraction, and those that had pulpitis that were undergoing root canal. And this is just the number of cartridges of local anesthetic administered into or around the intra-alveolar or the alveolar nerve, the infra-alveolar nerve. And more cartridges were required in the pulpitis, that is more local anesthetic. And in fact, there was failure in about 20% of the pulpitis patients, but we could get complete block in the controls. So if you block that afferent activity, these people, you can extract a tooth, which is a relatively painful procedure, were completely pain-free. So the local anesthetics, if you block the afferent activity, block pain. In my mind, just to sort of simplify things, everything after that sort of first noxious stimulus, I would consider pain after injury. And I've spent a lot of my career trying to identify the mechanisms that underlie that sort of, what happens after that initial injury. People have done a lot of work with the inflammatory mediators that drive this process that's referred to as sensitization, which is this increase in afferent activity. That increase in activity, afferent activity or excitability, correlates with this perception of hyperalgesia, that is increased pain in response to what was perceived as some normal intensity of pain, and or this emergence of a phenomenon referred to as allodynia, which is pain in response to normally innocuous stimulus. If you reverse sensitivity, that is, if you reverse the sensitization, the mechanisms that drive this increase in excitability, you can reverse the hypersensitivity. And I'm just going to give you a couple examples of that. This is an example of sensitization, some data collected a very long time ago. This is just an oscilloscope sweep. Each of these ticks is an action potential that's evoked in a C fiber. These is just a typical baseline response to a mechanical stimulus that's applied. This after is an injection into the receptive field of prostaglandin E2. And you can see, in this case, the same intensity stimulus drives more action potentials. That would be the underlying neural mechanisms of what is referred to as hyperalgesia. That is, you get this increased neural response to the same intensity, what would be perceived as a painful stimulus, and you get a drop in that, the threshold. This was the threshold before, this is the threshold now, and you can get afferent activity. So this would be the sort of classic example of sensitization, this increase in excitability. Drop in threshold, increase the number of evoked action potentials, and that correlates with the perceptive pain. From a mechanistic perspective, you could do an experiment where you're recording. In this case, this is a patch clamp experiment. This is a voltage-gated sodium current. So the other currents have been isolated, and just this inward current from a holding potential of minus 60 millivolts to 0, you get this inward current. And you can, if you evoke this current every 5 seconds or so, you get a nice stable baseline, relatively stable baseline. But if you then administer prostaglandin E2 very quickly, over a course of about 90 seconds or so, this current will increase in magnitude. And so if you can see the current before, this is the current after. This would be a mechanism, and just one mechanism, that drives this increase in excitability associated with sensitization, right? So PG2, acting through a cascade that I'm not going to get into at the moment, will drive this increase in the magnitude of this voltage-gated sodium current that underlies this increase in excitability. Right? That increase in excitability then contributes to what is perceived as the hyperalgesia and or allodynia. And you can administer then drugs to the periphery. In this case, Damgo is a mu-selective agonist, that is mu-opioid receptor selective agonist, a dose-response curve injecting higher and higher concentrations into the periphery, and you can reverse this PG2-induced hyperalgesia. Damgo alone in the periphery is not analgesic. That is, it does not elevate the threshold above normal. It just reverses this hypersensitivity, right? Consistent with the idea that the sensitization of these neurons is what's driving this hyperalgesia, this increased pain or the perceptive pain in response to injury. Again, underlying the contribution of the primary afferent to this. So what happens with time? You certainly get the ongoing action of inflammatory mediators. Anybody that's taken a nonsteroidal anti-inflammatory for an ongoing inflammation, sprained ankle, whatever, and get some relief from that is experiencing the benefit of what is the reversal of these actions, of these ongoing actions of the inflammatory mediators. You can start to see more durable changes in the primary afferent, changes in expression, changes in receptor number, changes in the density that all contribute to an increase in net input to the central nervous system. There's phenomena such as hyperalgesic priming, coined by the Levine lab at UCSF. after a time, these changes that contribute to excitability are no longer restricted to the afferent terminals, which from a therapeutic perspective becomes problematic, because if you want to potentially treat your pain with a peripherally restricted or with a therapeutic that's directed to the terminal, often you'll lose efficacy because the site of hyperexcitability has started to move towards the central nervous system, where a lot of attention over the last couple of years has been focused on the dorsal root ganglia itself, with a number of changes that have been described within the ganglia that contribute to this ongoing or increased input to the central nervous system. And then finally, and I won't have time to talk about them today, but a whole host of other mechanisms have been described in the periphery that also contribute to this increase in signaling, with more persistent changes in immune cells. A lot of attention has been focused on epithelial cells, particularly in the viscera, in terms of different types of epithelial cells that are changed and contribute to an increased afferent input to contribute to visceral pain. And of course, the sympathetic postganglionic neurons with an efferent limb seem to contribute to a number of different pain syndromes. So this would be peripheral mechanisms in general that would be contributing to pain. Just to illustrate what hyperalgesic priming is, these are some old data from the Levine lab, and what they're showing is that if you inject PG2, serotonin, or this is an agonist for adenosine receptor, this is oddly plotted as a decrease in nociceptive threshold going up this way, so more pain as you go up here, that the animals will show this hypersensitivity after about a half an hour, and this is time, that decays almost to baseline in 4 hours under normal conditions in response to each of these agonists. Again, these are peripherally administered, so this hypersensitivity is a result of the peripheral actions of these drugs. If you prime the system, in this case with a inflammatory insult referred to as carrageenan, it just produces a relatively transient hyperexcitability that can resolve relatively quickly, depending on the dose that you give. Now, what would last for 4 hours at the most is lasting for at least 24 hours. So the changes in the primary afferent are now, because of these more durable changes, the actions of even inflammatory mediators are potentiated in terms of duration. And you can see these changes lasting a very long time. So this is what I mean by some of these durable changes in the primary afferent that are contributing to some of these persistent or more chronic pain states, right? All right, so a whole host of factors, and we could spend a long time talking about the relative impact of each of these, but just relatively quickly, the type of injury matters. So when we're talking about underlying mechanisms that are driving this increase in excitability, the type of injury, whether it's more inflammatory, whether it's involving nerve injury, influence the underlying mechanisms that contribute to this persistent hyperexcitability in the primary afferent, to this increased input to the central nervous system. And people have described it, whether it's inflammatory, and not just the type inflammatory versus nerve injury, but whether that is impacting a cutaneous afferent, a muscle afferent, a joint afferent, viscera, above the neck, below the neck, seem to engage different mechanisms. Again, causing trouble from a therapeutic perspective, but from a neurobiologist perspective has been pretty interesting. We've already talked, particularly yesterday, the impact of timing, the history, the age of the animal. There's pain syndromes, trigeminal neuralgia is preferentially impacting people over 55. Some of these other pain syndromes occur much earlier. The previous history, early life stress, trauma, et cetera, time since injury can all influence underlying mechanisms, with the primary afferent changing in response to all of these things. Of course, sex is a variable. We've already talked about that a bit, and peripheral mechanisms are certainly influenced by sex, and of course, genetics contribute as well. So a variety of influences a variety of factors will influence the underlying mechanisms that enable the primary afferent contribute to the pain. All right, so I guess the next question would be then, to what extent do the changes in the CNS acknowledging that the CNS does influence the percept, depend on primary afferent input. And I'm just going to run through a couple of phenomena. This wind-up was described back in the mid-'60s by Loren Mendel. For those of you that use temporal summation in your quantitative sensory testing, this wind-up is the electrophysiological phenomena. That central sensitization is a term originally coined by Clifford Wolff to mean something really relatively specific to the dorsal horn. It's now a term that's broadly used for processes throughout the nervous system. Just quickly, I'm not going to show any data about this, but there was this debate around the formalin model. And if people aren't familiar with the formalin model, in a rodent, if you inject the fixative formalin into the hind paw of a rodent, you get this very stereotypical behavior. Well, you get this burst of activity that lasts for about 5 minutes. That is, the animal will show flinching and licking of its paw, very uncomfortable. You get this gap in any activity. The animal will walk around as if nothing's wrong for maybe another 5 minutes, and then it'll start to flick and lynch, or lick and flinch its paw again, and that'll go on for maybe another hour and a half, 45 minutes to an hour and a half. So it's this sort of biphasic response. And at one point, Ron Melzack of Melzack and Wall and the gate control theory was proposing that that second phase was the engram, was a sort of CNS echo of this initial pain experience that was reflected in that first 5 minutes of activity. And there was a lot of back and forth with folks at McGill really pushing this idea that there was this trace and where in the nervous system was it. Ultimately, I think the data would argue, with detailed recording of the primary afferent, that even this second phase of activity was still dependent on primary afferent input. It wasn't nearly the level of activity that you saw with this first burst, speaking to the role of a central sensitization, but it was this ongoing activity over that 45-minute window that gave that second burst of activity. Because if you blocked it, you would essentially lose that round of activity. Just talk a little bit about microglia, because from a neurobiological perspective, it's received a lot of attention. And then raise this question about plasticity in the spinal cord. Well, I won't raise the question, I'm just going to address it here. People have used this analogy to say, oh, the central sensitization is like memory. And that analogy was pushed because, as I'll show you in a second, when Clifford Wolff sort of coined the term and made the discovery, this was in the mid-'80s, and this was at a time when the folks that were working on mechanisms of learning and memory, Roger Nicole and Kendall and et cetera, working in hippocampus, showing, for the first time, LTP as a mechanism, long-term potentiation as a mechanism of learning and memory, because of this sort of convergent input of synapses and, detailing the mechanisms, it being NMDA dependent and so on and so forth. They pushed this idea that memory could be occurring at the spinal cord level, because Clifford Wolff showed that central sensitization was NMDA receptor dependent. As I'll show you in a second, that shouldn't be pushed as hard as it has been. That is, it's certainly central sensitization is memory dependent, but the available evidence would suggest that in contrast to memory traces, where you don't need that sort of ongoing activity to maintain that synaptic plasticity in the hippocampus, in the dorsal horn, you do. Let's see. So here's your example of, This is your example of of wind-up. So this is Loren Mendel working with Pat Wall, published back in 1965. What you're seeing here is the responses. So this is time is in this direction. Each of these dots is an action potential, and this is in response to repeated stimuli. This is electrical stimuli at intensities to evoke both A fibers and C fibers, and this is A fibers alone. And in response to A fiber activity, you get a pretty consistent barrage of action potentials that last for about the same amount of time. So no evidence of changes in the response to the central or dorsal horn neurons. What they're recording from are neurons in the dorsal horn, and this is their response over time. And in contrast, if you're stimulating at C fiber strength, hopefully you can see, it's not so clear in this raw data image, but you can see an increase in this sort of duration, and really it's the number of action potentials that are evoked over time. And this is the electrophysiological phenomena, as I was saying, of temporal summation. That is, if you're stimulating at about 3 hertz or faster, that is, up to 1 hertz is sort of a classic time frame, you're going to see this increase in the dorsal horn response to repeated stimuli. And as you showed, Roger, didn't you, some temporal summation data? So as is, the human percept is with each of those stimuli, they report it as being more painful. And that increase in pain, even though the barrage isn't changing, the intensity of the primary afferent stimulus isn't changing, because of the CNS plasticity, the percept is going up, right? Consistent with the idea that certainly the CNS is a gain modulator. This is a sort of cartoon that Clifford generated in this review published in 2011 of central sensitization, a phenomena that he published as a single author back in 1983. He used a burn injury to produce these changes in the dorsal horn neurons, but he was recording from dorsal horn neurons and looking at the changes in responses after he produced a manipulation in the periphery, and described phenomena that would be consistent with, again, more mechanisms to account for hyperalgesia. That is, that you got increase in responses to intensity of stimuli that drove the primary afferent, as well as now the emergence of activity in this, what would be a projection neuron along a pain pathway in response to low threshold input, which would be sort of a classic mechanism of allodynia. And this was shown to be NMDA receptor dependent, heterosynaptic, meaning that it could recruit different populations of synapses. It lasted longer, so this lasted 45 minutes to 90 minutes, these changes. And it didn't require this sort of synchronous burst that Mendel described for windup. That is, the stimulus could be a natural stimulus applied to the tissue that could produce activity that was asynchronous in nature. But it was a burst of activity or intense activity that was requiring it. The key take home here, though, is that if you take away primary afferent input, these changes that Wolf described go away, right? They are not, they don't exist independent of that afferent input. So if you've taken away any of this drive of the nociceptors to maintain this, and what is required to maintain it is much lower levels of activity, essentially this form of plasticity will resolve. Okay, so even though it's a clear gain contributor, and Dan was telling me he's going to ask some questions later, I certainly imagine the CNS as being a gain modulator in the pain, and this would be a great example of a way of increasing the gain. That change is still dependent on the primary afferent input. Okay. And again, this is a trip down memory lane. But in my mind, this is one of the best examples of sort of the central sensitization phenomena. This is some data that was out of Bob Lamott's lab working with Eric Torbjork. And they were using this approach referred to as microneurography. And in this case, instead of recording, they were stimulating. So you use this small electrode that's sticking in the nerve. And the electrodes are small enough that you can stimulate basically just a couple of fibers. And in this case, they're stimulating a fiber that produces this tactile sensation out on the foot. So they've got a single unit that has a receptive field on the foot here, and they inject this capsaicin outside of the receptive field of this unit that they've been recording from. Capsaicin, if anybody has experienced it, is the active compound in chili peppers that gives you that burning sensation. That produces not only what is referred to as a primary hyperalgesia or increased pain at the site of injection, but the secondary hyperalgesia. And in this case, that secondary hyperalgesia expands into the receptive field that was originally encompassed by this or resulted in this sort of tactile sensation. But interestingly now, when you stimulate at the same site, the perception is both the tactile sensation and pain. This would be the emergence of allodynia as a percept. And it's allodynia that is being driven by changes in the central nervous system secondary to this activity in the primary afferent. Okay? So it still is primary afferent dependent. It's being driven by capsaicin here that is producing changes in the central nervous system that now enable this to be perceived as pain, or would be the sort of neural correlate of allodynia. And as this hypersensitivity resolves, the normal tactile sensation is restored. All right, so just a couple words about microglia, because that received a lot of attention a number of years ago. This is a picture of a dorsal horn. This is the dorsal horn, or sorry, of a spinal cord. Dorsal horns up here, ventral horns down here. This is contralateral and ipsilateral to what is referred to as a spinal nerve ligation, which is a traumatic nerve injury. The section has been stained for OX42, which labels microglia, and hopefully you can see even in the back of the room that there's more microglia staining on the side associated with a nerve injury. And so a lot of time and energy was put into looking at these microglia as a potential cause of the central sensitization and as a potential therapeutic target. And some really beautiful sort of neurobiology, I would argue, was really developed as a result of a whole series of studies that were done in Japan and Canada. Primarily, the investigators were running those studies, but has been really replicated around the world. And the idea in this cartoon is sort of illustrated as what happens over time. And you have your resting microglia that are sort of in this quiescent state, and that with nerve injury, you start to see these changes in the microglia. They hypertrophy, they proliferate, they start to express receptors, in this case a receptor for ATP, the P2X4 receptor, and then when ATP can act on them, they release, in this case, brain-derived neurotrophic factor that acts on dorsal horn neurons through this TrkB receptor to influence this potassium co-transporter that influences the chloride equilibrium potential, ultimately resulting in a decrease in the efficacy of GABA inhibition. Okay? Many steps here, very complicated, many papers, a number of them in Nature, very high profile. Like I say, replicated in labs around the country, very robust phenomenon. As I'm arguing, the details here are really beautiful in terms of how they've been worked out, the number of different mechanisms. The key component to draw your attention to, though, is that all of these changes are dependent on the primary afferent. It's interferon gamma, or CSF1 from the primary afferent that is initiating this whole hypertrophy in the microglia. So these changes don't occur without the primary afferent, and they aren't maintained without the changes in the primary afferent that contribute to them. Unequivocally, these changes contribute to the hypersensitivity, right? When you lose inhibition in the dorsal horn, which is an experiment I advise none of you to do, things don't go well, particularly for the perception of pain, right? GABA signaling in the dorsal horn is important for normal percept, and particularly the normal percept of pain. And this mechanism contributes to why there is more input and is perceived as more pain. And then, of course, the changes in the dorsal horn is just one of the nodes along the way. There's changes in the parabrachial nucleus that have been described. We heard a little bit about the amygdala as well, changes in the amygdala that contribute. Of course, a lot of attention was put into changes in the descending input, the classic descending input, what would mediate normally descending inhibition to attenuate pain, from the PAG to the rostral ventral medulla, on down to the spinal cord, with evidence that the RVM switches from being inhibitory to excitatory. And so that now the RVM, which would normally be driving descending inhibition, is now driving descending facilitation to further increase pain processing, or at least the ascending signal in the pain component. I guess then the question becomes, to what extent does the persistence, or to what extent does the persistence of these changes depend on afferent input? And that really is, I think, the question that we'll hope to resolve here, because in my mind, it's this open question, right? the preclinical data would argue that in the vast majority of cases, these changes, even at the peribrachial level, the descending facilitation, do not exist on their own. That is, if you take out the primary afferent input, these changes resolve. Frank Borek and his group would argue that it was actually an upregulation of NPY in the low threshold afferents that through gracilis ultimately signals to the RVM to drive this descending facilitation, right? So it was plasticity in the primary afferent that was ultimately driving these changes in the CNS. And why, in some people, or I would argue many people, does all of this sort of amplification mechanism exist, contribute to their pain, but basically depend on the primary afferent in some cases and apparently not in others? I would argue is a really major open question to address. To just push on this theme a little bit more, and we were talking about it, and certainly migraine might be the odd duck. It clearly is a pretty unique pain syndrome. Its manifestation, its timing, a whole host of reasons to describe it. But I think it's a mechanism that illustrates a proof in point. Because on the one hand, the brains of migraineurs are clearly different, right? The migraineurs will show greater evoked potentials to auditory stimuli or other somatosensory stimuli. So their brains tend to be hyperexcitable, but in the interictal phase, they don't show more pain, right? If they don't have a migraine going on, they're basically, you couldn't distinguish them from normals. So they're pain-free between attacks. And the headache, that is the pain of migraine, at least the consensus now is that it starts with afferent activity. That is, the neurons that are innervating the dura in the head the sensory neurons seem to be the critical leg in what's mediating the pain of a migraine. And with an initial attack, that is when somebody has their first migraine, basically they have a headache. They might have, if they've got migraine with aura, the aura first. They'll have maybe a prodrome if they were even aware of it. They might have the postdrome. But it really is that the headache is the primary experience. But with the frequency and severity of attacks, you start to see the emergence of this phenomenon referred to as allodynia, particularly in the ophthalmic division. People will find, like if you're wearing glasses, you don't want your glasses touching your eyebrows. There's sort of classic mechanical allodynia during the migraine attack, but not after or between. And with the frequency of severity, that will go from the ophthalmic division into the full face, and then ultimately take over the full body. And this has been described as sort of as a classic manifestation of central sensitization because of this afferent input. And Burstein and his colleagues have described sort of this centralization process that occurs with ultimately the sensitization of the thalamus that accounts for these larger receptive fields in the dorsal horn, in the manifestation of the hypersensitivity. And that's been followed up, and they've actually been able to show in imaging that you can see the same responses during the ictal phase of a migraine in humans, that you can start to see activation of the thalamus with what would be innocuous stimuli. It appears to be the case that this frequency and severity drives the emergence of this central state. And these are two data sets were collected for slightly different reasons, but basically come to the same conclusion that the frequency and severity of migraines really drives the manifestation of this sort of centralized phenomena. But for me, it illustrates a critical point, which is that you can get to a full body pain with afferent input, right? That is, that the afferent input can drive this manifestation of hypersensitivity throughout the body. But the fact that they are pain-free again in the interictal phase would suggest that those changes in the CNS go away, right? They don't persist in the absence of the afferent drive, which I think is a critical point. Let's see, peripheral drivers, classic for nodoplastic pain. So just to throw out, there certainly is, it's a heterogeneous group in fibromyalgia, but there is evidence of at least some peripheral drivers in these, what would be the classic sort of central nociplastic pain syndrome. There's a single microneurography data, as we talked about. It'd be great if that was replicated. And despite the fact that Dan has raised, I think, some appropriate concerns about some of the work coming out of Boston in this regard, but there are groups that have also implicated immune dysregulations potentially contributing. And just to quickly show you those data, so again, this is this microneurography technique. Anybody that was at the ISP meeting in 2018, I was a subject for a microneurography experiment with this guy, Jordi Serra. And it was pretty impressive that in basically an auditorium like this, he was able to, string me up and identify a polymodal C fiber and, showed the delayed latency and all that kind of stuff. But, this is a single trace. This is the sort of action potentials from a bunch of the different nerves that he's recording from, but the one that he's following here, you see these sort of classic delays depending on the activity. And the sort of what they think are most important, they being Jordi Serra and his group, think are most important for pain are these mechanically insensitive, which really only start to show this delay in their response latency when there's spontaneous activity that's emerged. And that's what's causing the delay, is sort of this ongoing activity in these afferents. But what they reported in this paper is that there was both an increase in spontaneously active units and mechanical sensitivity in these classically mechanically insensitive afferents in both fibromyalgia patients and patients that had small fiber neuropathy. Again, it's a study that's only been observed once, and it would be great if it was replicated. But just really quickly, as I'm wrapping up here, evidence for immune dysregulation. This is Emerson Kroc, who's now at McGill, who's working with Camilla Svensson in Sweden. And what they're showing, these are mouse satellite glial cells that have been probed with IgG that was recovered from fibromyalgia patients or healthy controls. And you can see the IgG staining goes up when you're taking the serum from fibromyalgia patients. This is glutamine synthetase, which just lets you identify the satellite glial cells and the merged image. And these are the pooled data from something close to 30 patients in each. I think it was 30 and 29, with on average higher IgG positive SCG. And they've been sort of working through the mechanisms of how IgG may be signaling the satellite glia within the ganglia to drive this overall hypersensitivity. So back to peripheral versus central. Again, I would acknowledge that changes in the CNF are certainly sufficient to account for hyperalgesia and allodynia, accounting for ongoing pain. But the question is, if this happens, when and why? Why is it that the 80% of people that get a total knee replacement who might have been in ongoing pain for years prior to their replacement are basically pain-free after the knee is replaced? That tooth pulp study that I showed, the average time in pain that these people are saying they were at a 9 or above on the visual analog scale, excuse me, was 11 months. You pull that tooth, they all walked out of there pain-free. So what is it that for some people it becomes, this becomes sufficient and in many others not? It doesn't appear to be time dependent. As I said, you've got people that have been in pain for many years and you can resolve it with a peripheral therapy. And it doesn't appear to be injury dependent either. So there's something potentially unique. And so I guess the question is, the example of the peripheral drivers, even in the most classic cases of central nociplastic pains exist. So it's sort of, how do we differentiate between them? And that would be hopefully I didn't take too much more than 20 minutes.
So I don't disagree with hardly anything you said, so. So for the last 15, 20 years, nearly every talk that I give, I start with this slide. I'm trained as a rheumatologist, and until the mid-1990s, it wasn't just the pain field that was incredibly peripherally focused. All of clinical medicine has been and still is very peripherally focused. They think if someone has pain, it's got to be a problem in the region of the body, and it's going to be fixed by surgery and injections and things like that. So I'm going to talk a lot about osteoarthritis today as a model for how we can actually study both central and peripheral factors. But the thing that'll surprise most of you is that 30 to 40% of people in the US population, I don't have any reason to believe it would be any different anywhere else, that have an x-ray like the one on the right. They've lost all their cartilage, they have bone rubbing against bone. 30 or 40% of those people don't hurt. They have no pain. It's totally asymptomatic. And that, again, is every pain syndrome you see this, every pain syndrome you see, whether it's low back pain, osteoarthritis, every pain syndrome, there's a terrible relationship between anything you can measure in the periphery with respect to joint space narrowing, inflammation, or anything, and whether someone has pain or how severe that pain is. And this is my career. In 35 years, I was taught that osteoarthritis was the classic peripheral pain syndrome. Then in the 90s, these studies began to show up where it was like the joint space narrowing had little to do with whether someone had pain or not. When we see people that have pain that we can't see on an x-ray, we immediately blame psychological factors, and I'm not trying to say psychological factors are unimportant, but for this, in this context, psychological factors were playing very little role in explaining that variance between how much pain someone had and what their x-ray looked like in osteoarthritis. And even the therapies that I was taught worked really well, like nonsteroidal anti-inflammatory drugs, acetaminophen, and opioids. Now look at the Cochrane meta-analyses for these nonsteroidals. Have an effect size of 0.3 or 0.35 in osteoarthritis. They don't work very well at all. Acetaminophen, I'm not sure it works for chronic pain. And don't get me started on opioids. I'll do a little mini opioid rant in just a minute. And we have used arthroplasty as a model. I'll show you some of those data where we've looked at arthroplasty or surgery that for chronic pelvic pain, hysterectomy for chronic pelvic pain, as sort of a model for the central contributions to pain. So this is an article that was published in Pain earlier this year. I was a reviewer and I was asked to write an editorial, but it was a really nice study where what they did was use the UK Biobank, and they used GWAS to estimate the peripheral and central contributions in osteoarthritis, and their surrogate for peripheral was BMI, or how heavy someone is, because we know that is a very strong risk factor for osteoarthritis, for peripherally induced pain. And the corollary for central was how many sites of pain people had, the widespreadedness of pain. And in this article, that you can see the data here, both peripheral and central factors were important. And at the end of the day, they said it was probably about 40% central and about 60% peripheral. The central factors are a little more prominent in the odds ratios, but the scale for the BMI was different. And so in the end, it looked like in this huge database that about 60% of the pain in osteoarthritis using these techniques was coming from peripheral factors and about 40% from central factors. And that actually makes perfect sense to me, given all the work we've done in osteoarthritis. Of course, they asked me to write an editorial. I wrote an editorial that had nothing to do with the article, but it just went on a rant because it turns out that just giving someone a body map and seeing how widespread the pain is turns out to be an incredibly good measure of whether the pain is coming more so from the central nervous system or whether it seems to be entirely peripherally driven. And so our group has spent a lot of time and we've been involved in the metamorphosis of thinking about fibromyalgia, from the early criteria of fibromyalgia to more recently when now this is really thought to be a legitimate condition in the pain field, and in fact it's sort of the poster child for, if you will, nociplastic pain. And this is an analogy that I've been using a long time, and it's one of the questions I'm going to ask Michael to comment on, because I've been using this analogy for 15 or 20 years, and I wonder if it makes his head explode or not. And that is, if you take those two knees that I showed you earlier, we can see how someone that doesn't really have anything much going on in their knee could have pain, and someone that has a lot going on in their knee could not have pain, because all of that peripheral input has to come through the spinal cord in the brain, and the spinal cord in the brain really acts as an amplifier. It can either turn up the gain, which is a lot of what Michael has been talking about, but what's equally important is it helps understand why so many people that have gnarly looking knee x-rays don't have any pain, because it also can turn down the pain. So the reason, for example, that almost every chronic pain syndrome is 1.5 to 2 times more common in women than in men is women have a higher amplifier setting. They don't have more. In osteoarthritis, this is very clear. Men and women at the same age have almost exactly the same rate of radiographic damage to the knee, but at any point in time, women will be 1.5 to 2 times more likely to feel that because their amplifier on average is set higher than men. And if it's not annoying enough, if they're actively menstruating, it's moving around and changing. And so those of us that have been studying central mechanisms, it was sort of a big deal when the IASP sort of voted that this third descriptor of pain, which we're going to call a mechanism, was finally sort of legitimized because, again, I think there's an overwhelming amount of evidence that this is nosoplastic pain is a real thing. And it's not just pain. These individuals, the sleep problems, the fatigue, the memory problems, the mood problems, and the sensitivity to stimuli that are not painful stimuli, to the brightness of lights, the loudness of noises, odors, that has to be central. Sensitivity, those are cranial nerves. Those are not, there's no input from the periphery that's influencing those. Those are coming right directly into the brain. And this is a marker that we're seeing in a lot of our studies, the brightness that someone judges a light on quantitative sensory testing and data that we're imaging now is a strong predictor of someone not being responsive to knee arthroplasty if they have their knee replaced. Because again, what you're doing is sort of measuring, if you will, that sort of sense of amplification that's occurring in the central nervous system. And so we don't like the term, but we're living with the term, the nosoplastic pain term. Another term that's being used a lot more in Europe and outside of the United States, where the ICD criteria are a lot more strongly used, is primary pain. And what primary pain means is that the pain is the primary problem. It's not coming from rheumatoid arthritis or osteoarthritis or whatever. And so these conditions that Dave and Roger and Bill called chronic overlapping pain conditions, and which now are called primary pain by the ICD-10 and ICD-11, are these conditions that the most common pain conditions are in fact conditions where nosoplastic mechanisms seem to be a prominent, if not the most prominent mechanism in all of these pain conditions. And we know that these same phenomena play significant roles in pain conditions that start out as being nociceptive or neuropathic. And so, again, I'm trained as a rheumatologist. We know that about 30% of individuals with any autoimmune disease will meet criteria for fibromyalgia, have central sensitization, have nosoplastic pain, whatever those terms you want to use. We know that that's a very common. And the other thing that we know, and Michael, this might be of interest to you, the reason that I am so against fibromyalgia being an autoimmune disease is we take care of people with autoimmune diseases and we treat them really aggressively with biologics, and that component of their pain doesn't respond to it. You'll talk to any rheumatologist that takes care of patients now, and the advances in our biologics have made incredible improvements in our ability to treat the inflammation associated with autoimmune diseases, but 30–40% of these patients still are miserable. They have pain, fatigue, memory problems, and sleep disturbance, in spite of the fact that we've been able to knock down their inflammation by any way we can measure it, but they still have that persistent CNS pain. And so we've used the fibromyalgia criteria as a measure of a surrogate measure of nosoplastic pain, because it not only has a body map, but it also actually asks people about these other symptoms like sleep problems, fatigue, and memory problems. And again, it's becoming increasingly clear that these problems are inherent to nosoplastic pain. The strongest risk factor for developing nosoplastic pain is starting out with a sleep problem. And in the ABCD study, the article that Chelsea and Andrew wrote looking at new onset of multi-site pain in ABCD, again, the biggest predictor was a sleep problem or a memory problem, and these were the kids that were at highest risk for subsequently developing pain. And that's been found in adults using the UK Biobank as well. And so we wrote a recent review in Nature Reviews Neurology. I was floored when Nature Reviews Neurology asked us to write on nosoplastic pain because neurologists are the biggest fibromyalgia haters in the world. And so I'm sure a lot of them are livid when they saw that in their journal that there was an article on nosoplastic pain. But there's a couple of nice figures from this article. These are talking about some of the risk factors for developing nosoplastic pain. We talked about a lot of these yesterday, and some of them are clearly trauma, maltreatment. Some of these are clearly things that, again, are much more likely to be centrally mediated rather than peripherally mediated. And this is an amazingly busy slide, but there are a fair number of findings in the central nervous system, either levels of neurotransmitters, different changes in functional connectivity that have been reproducibly identified in individuals with nosoplastic pain. In that article, we highlighted a couple studies that we think actually really go a little bit further and show that the CNS problem often antedates the development of the pain. This study, which I think is one of the coolest studies that's ever been published by our group, this was led by Chelsea, again, mining the ABCD study, which takes healthy children at age 9, does functional brain imaging, asks them a lot of questions, and then follows them longitudinally until they're age 18, and does functional brain imaging every 2 years, asks them a bunch of different questions. There's 12,000 or so kids in this ongoing study that's being done in the United States. And we were the first to mine the ABCD study for pain findings, both the clinical findings that I just alluded to, where the sleep and the memory problems antedated the pain, but these imaging findings where that the kids at age 9, they have to be pain-free and healthy to get in the study. They get a functional imaging study at age 9. The kids who 1 year later developed new multi-site pain, those were the cases, the other kids were the controls, had 2/3 of the imaging findings we see in adults with fibromyalgia with respect to connectivity, but they were pain-free. They were totally asymptomatic. What we were imaging was really a diathesis or a risk for subsequently developing nosoplastic pain. And this is another study that Irene was involved in that was published recently. Again, I think that a lot of neuropathic pain it's not the nerve that's the problem, it's how the central nervous system responds to that damaged nerve. And if your central nervous system has a high amplifier, you get pain if you have nerve damage. If it's a low amplifier, you have painless neuropathy. Only about 50% of people with any kind of nerve damage actually have pain. Many of them have a decreased sensation. But this study showed that you could identify the individuals who, after chemotherapy, were going to develop chemotherapy-induced neuropathic pain on functional neuroimaging. And so in the Nature Reviews thing, we have talked a lot about what we think is top-down nosoplastic pain. These are the individuals that develop nosoplastic pain very early in life, in childhood and adolescence. And this is where you see that girls, as they turn into women, start to develop 1.5 to 2 times the higher rates of pain. And I would argue that being female is largely a central factor here when we're talking about this. But we think that those individuals that early in life develop growing pains, functional abdominal pains, headaches, fibromyalgia, that those are individuals that really seem to have a primary brain disease. It's not clear that there's any really ongoing nociceptive input that's driving that, whereas there's other individuals that clearly have, again, what is somehow activity dependent, or it's bottom up, where it is peripherally maintained, and if you can eliminate that peripheral nociceptive input, then you can actually lead to a significant improvement, not just in the pain, but in some of these other symptoms we see in nosoplastic pain. And so this is looking at individuals getting knee and hip replacement surgery, and you could identify clearly 2 different groups. A group of people that had knee and hip replacement surgery that had dramatic improvements, not just in their pain, but this was in their whole fibromyalgia score, and you can see also what happened to their body map. But there's another group of individuals that didn't have any improvement. And so, again, we think that there's, and within a group of individuals with osteoarthritis that are in their 60s, 70s, 80s, you would expect that some of those individuals would be people that have the sort of top-down form of nosoplastic pain, and they just got to be 60 years old. Others have more of the bottom up. It is being driven by their osteoarthritis, and that's why both their osteoarthritis and some of these other comorbidities improve when we do knee replacement or hip replacement surgery. And we actually showed this in a GWAS study that we published several years ago. This is, again, samples and data that Chad and his group had collected, where we showed using GWAS that the heritability of the fibromyalgia phenotype, which is sort of the nosoplastic pain phenotype, is much higher in younger individuals. And you see that there's a strong familial coaggregation of headache, fibromyalgia, irritable bowel in younger individuals. And then those conditions, those top-down conditions, actually get a lot less common as people get into their 40s and 50s. All of those chronic overlapping pain conditions have a tendency to peak in age 40, 45, and then decrease in frequency as people get older. When you look at the drugs that work in these conditions, these are all really centrally acting drugs. We see that in a lot of these drugs, again, we and others have done a lot of work looking at all the different neurotransmitters that can either turn up or turn down the amplifier or the volume control in nosoplastic pain conditions. And there's just like in the periphery, it's very complicated. In the central nervous system, it's very complicated. One of the differences in the central nervous system is a lot of these neurotransmitters that seem to be awry in nosoplastic pain are pleomorphic, and things like glutamate or norepinephrine or things like that. They do a lot of different things in the body and in the nervous system, which is why we think that this is not just a pain problem, it's a sleep problem, it's a mood problem, it's a memory problem, it's a big problem. But it turns out that the drugs that work in conditions like fibromyalgia, and by the way, if you look at the drugs that work in neuropathic pain and the drugs that work in fibromyalgia, they're identical, and I don't think that's accidental. I think that we're treating the CNS hyperactivity in most individuals with neuropathic pain. But again, all of these sort of make sense given what some of the neurobiological studies have shown. This isn't really relevant to our discussion, but I'm going to do a 3-minute opioid rant because every year of the pain short course, I need to do this and make people that are taking care of patients less comfortable giving opioids than they are right now. I and others are really worried that in these nosoplastic pain conditions that the endogenous opioid system is actually involved in the pathogenesis. This was a PET imaging study with carfentanil, with fMRI that we did in fibromyalgia, and all the brain regions that were abnormal on functional imaging were also abnormal in the carfentanil PET, and it really looked like part of the problem in fibromyalgia was these individuals were releasing too many endorphins and enkephalins, and they really had endogenous opioid-induced hyperalgesia, that because of the over-release of their endogenous opioids, that it really looked as though that was driving this. And there's only been, let me just challenge the audience, if anyone knows of a single parallel group randomized controlled trial of an opioid in chronic pain for 3 months. I don't. I've looked at all the literature. All the studies that showed opioids are effective were randomized withdrawal designs. The only opioids that had parallel group designs are tapentadol and tramadol, the mixed, where there's other reasons that those drugs would have been effective, but the pure mu opioids, and not counting buprenorphine, the pure mu opioids, there is not a single, I cannot find a single parallel group 3-month trial, let alone a 1-year trial. But there have accidentally been 2 1-year trials done. The first one was Erin Krebs' trial, where she compared in low back pain and chronic pain patients, NSAIDs, opioids, randomized people, followed them for a year. This was in the bottom part of the results, but it turned out that the individuals that got opioids had a statistically significant increase in pain at 1 year compared to the individuals that got nonsteroidals. The reason that the high-level data that was presented was the pain interference was the primary outcome, so that was what was reported first. There was no difference between the people that got opioids and NSAIDs. But you know, imagine, again, a trial where what we think is the active treatment, opioids, actually are statistically worse than, if you will, the comparison group here. And then this was a trial published more recently that was supposed to, a trial nominally looking for acute effects of NSAIDs versus opioids, the OPAL trial, but they followed people for a year. And look at how poorly the people that got randomized to the opioids did. And again, this is another graph. Entirely flipped if you're looking at things. It's the opioid-treated patients 1 year later, pain intensity was statistically worse than the individuals that at the beginning of that trial got randomized to NSAIDs. Now, we don't know what happened to them after they got randomized to NSAIDs and opioids, but these are the only two long-term trials that have ever been done of opioids, and both of them show the same thing, that opioids made pain statistically worse in the individuals compared to giving them a non-steroidal anti-inflammatory. So, and so until we have data that refutes this, I think people have to be a lot more careful. This is my cortical tattoo. Is it like any provider here, when you go and prescribe an opioid, I hope that you think about this, because I'm really concerned about this, and I don't think we as a field are as bothered as we should be by the fact that in 2023, 40% of the patients in the United States with fibromyalgia were getting oxycodone or hydrocodone, strong opioids. We don't know that it helps them, and we're really worried that it makes this kind of pain worse. And again, for our Ukrainian friends that are going to be treating a lot more chronic pain, please be careful about opioids. In every country, when people start to get too liberal about opioid use, it causes problems. And then the last couple slides, I'm just talking about all the non-drug therapies that we use for chronic pain states, especially nociplastic pain states. Again, most of these things seem to be peripherally driven, and it's really cool now that we have all these different forms of cognitive behavioral therapy, some that are aimed at improving sleep, improving physical activity, some that are more trauma-based, but our therapeutic options have really widened tremendously with respect to the non-pharmacologic therapies and the evidence base for non-pharmacologic therapies. So my questions for you, my first one is, why'd you agree to do this? Why don't we sit down now? Because I just have a couple questions. So what did you think you were getting into?
I don't know. I have this sort of if you're not you're a sadist? No, you're a masochist. I guess I have this masochistic tendency. And, I hadn't, long reason, I haven't been competing the way I wanted to this summer. I haven't taken the abuse I needed. I figured this was my opportunity to get what I hadn't been getting for the rest of the summer. So.
Well, how did it turn out? Did it feel abusive, or are you going to need therapy?
Well, I don't know. We're not quite done yet.
Okay.
Still a little bit of time left in this hour.
We have a lot of psychologists in the audience. I'm sure they could give a brief intervention if you need one.
Right. Yeah, no.
Okay, so let's talk about a pain question. What was the next one? So I think that this is really perhaps one of the most interesting things to talk about. Do you have to have nociceptive input to have pain? The analogy that I use when I'm talking to patients is that everyone has been sitting in this room now for an hour, and most people don't have any pain in their back and their buttocks. Some do. If you actually have a higher amplifier setting, if you're a fibromyalgia patient, you have pain right now in your back and your buttock. Sitting in a chair is a quantitative sensory test. When I used to give lectures for chronic pain patients, I was a dope, because we had a lecture room, and half of the chairs were like the regular hard chairs, and half of the chairs were the soft chairs, and the fibromyalgia patients, they went to the one side of the room. It's like, why are you guys all sitting on that side of the room? Is it actually daily nociceptive input, just sitting in a chair, day-to-day activity, is not supposed to be painful, and in most individuals it is not, but in these individuals with conditions like fibromyalgia, it becomes so. So that's why I'm sort of wondering, when we say nociceptive input, like something as simple, day-to-day life, there's nociceptive input like all the time.
Right. Yeah, so the problem still becomes, how do you differentiate whether that, what would be normal stimuli, is perceived differently because the brain is different or because those afferents are different. And that's the hard one. The problem, you put up the radiographic data, and we use the radiographic data in those grants that we write as well. It's not a predictor, so on and so forth. but it's a really crude assessment tool. And we speak about inflammation in relatively monolithic terms as well. And yet now with the Illumina arrays and so on and so forth, I mean, we can look at, to me it's amazing that nonsteroidals have any efficacy when you look at, when we do analyses of what we get out of people's knees, there are hundreds of mediators that are all upregulated 10, 15, 100-fold. And then cyclooxygenase takes any, because the whole handful of those that I've studied alone and that others are sufficient to drive sensitization of primary efficacy. So if you take out TNF-alpha, you still have IL-6, IL-1 beta, a whole host of others that are able to do the trick. And so, I mean, the bone-on-bone is crude and simple inflammation. Is there swelling? Is there redness? I don't think begins to get at the issue. People make the same with painful bladder syndrome. You do a biopsy, you don't see any change in the bladder. We have data from biopsies of bladder patients. I can put the epithelial cells of the bladder in a dish, passages them 10, 15 times, as was published in Neurourology, and I can still tell the difference between epithelial cells from a painful bladder syndrome patient and those not. It speaks to epigenetic mechanisms, but it's nothing that you can ever see just by scoping a bladder, right? I mean, these are the response of these cells. And so I think too quickly we jump to the idea, well, A, there's no correlation with the radiography, and B, I don't see anything else, so it must be central. And I think we do that at our peril.
Okay, well, I'll tell you about some data in painful bladder syndrome, because we were involved for 13 years in the MAP network. And one of the articles that's under review there, the biggest finding we found in the MAP network, which everyone that was involved in the network agrees, is that a lot of the individuals that come in with what used to be called interstitial cystitis is now called bladder pain syndrome, actually have widespread pain. And in fact, about 60% of the individuals in the MAP network that came in with the diagnosis of interstitial cystitis actually, on body map, had really more nosoplastic pain. But at the end of the map, we looked at how people with different phenotypes responded to certain treatments. Because again, I think that's where the rubber hits the road. Even though the sample sizes were only about 30 or so, this article's under review right now, the individuals with the widespread pain phenotype for bladder pain syndrome selectively responded to drugs like duloxetine and tricyclics. And the individuals with the pain confined to the pelvis responded well to physical therapy. The others didn't respond at all. The peripherally directed therapies didn't work very well at all in the people with the more widespread pain, and the drugs that are, again, treating the CNS component. And we are seeing that over and over again in a lot of the studies, like duloxetine, for example. In osteoarthritis and in chronic low back pain, it works much better if the people have multiple sites of pain rather than a single site of pain in the back or a single site of pain in the knee. So I think that where I think the rubber is hitting the road is where we're trying to take using body maps into precision like medicine studies with respect to what treatments are going to work. And what we're finding over and over again is that a body map is really quite predictive, especially if a therapy can either be said to be, this is a peripheral therapy like surgery, or this is a central therapy like duloxetine. A lot of therapies work in both places, and it would be hard to know what to...
Yeah. So the only thing I would caution in that context is the assumption that duloxetine is a peripheral therapy. Certainly canonically it is, and on the pain boards it is, that this is facilitating a descending antinociceptive circuit, except the data suggests it also blocks voltage-gated sodium channels. And the plasticity in voltage-gated sodium channels is going to be, as I suggested, site-dependent, injury-dependent, et cetera, and it wouldn't at all be outside the realm of possibility, and I think there's some data to support it, that depending on the type of pain, the relative changes in sodium channels that confers duloxetine sensitivity may be such that it in fact is acting peripherally, despite the assumption that it's a centrally acting drug. So I think, I take your point completely that canonically we view these things that way, but I think it's, particularly with pharmacology, is a mistake to make assumptions about where the drugs are acting.
Okay, so then how about surgery? Would you agree that surgery is a peripherally directed therapy?
Yes.
And again, our studies both in hysterectomy and in knee and hip arthroplasty strongly showed that.
Yeah. So the surgery is an interesting question to me, and in the knee OA, it's interesting as well, particularly when you think about revision. So in the last retrospective study that we did, about a third of the patients in the hospital that we were looking at were getting revisions. And they're reporting pain almost identically to the patients who had pain to start with. And that pain is relieved with the peripheral intervention at basically the same rates. It's still 80% or so successful. To me, that's suggesting, one, it supports the notion that the bone-on-bone really isn't the problem here. Two, that you could still have a peripheral driver, but that three, you have a phenotype of an individual who even, my assumption is that what's happening, and you still see this, that the replaced knee has been, the synovial tissue has reformed around the artificial knee, that has been reinnervated. You're essentially removing all of that tissue with the innervation, and I would argue that's what's providing the pain relief in that context. And so then the question is, what is about those individuals that the pain, and it's still now, it's manifested, use-dependent pain. Their weight bearing is a problem, walking is a problem, that those nerves have been sensitized to the point, when they're reinnervating, that they're being engaged such that they're driving this pain syndrome again. I think it's an interesting question, but to me, that still is arguing for a peripheral driver.
Okay. I'm curious. What do you think about the sort of guitar analogy and the notion that what the central nervous system is capable of doing is either in both directions?
Yeah. No, I completely support the idea. I think it would certainly account for why you have a whole host of people. I've been having these issues that I just noticed. I've got complete bone on bone in my back, stenosis, the whole 9 yards. I've got a big pain problem, but none of it's driven by my back right now, at least according to the physical therapist. So minimally, what should be a driver for me is not. Is that because I don't have enough inflammation, because we just submitted a grant for looking at discogenic pain and the bad nucleus pulposus cells as being the driver? Is it that those mechanisms aren't sufficient in me? I don't know, but I would certainly agree to the notion that I don't have the volume turned up in terms of transmission, and I've got enough inhibition turned down to zero out whatever's going on as the driver in that case. That makes complete sense to me, and it certainly, particularly with your analogy of the transition as people, with sort of age-dependent changes, as that volume, knob is modulated through life events, is another analogy that makes perfect sense.
The other reason that I like it clinically is I try to get people, to force people to think that often these are in combination. Someone with a little bit of peripheral input and a lot of amplification still might benefit from a peripherally directed therapy, either because it's activity-dependent central sensitization or that getting rid of a little bit of the pain is, but I think a lot of people have a tendency to think of this as either or, and it's a combination of like peripheral plus central augmentation, and I think clinically that's an important message to teach people.
But the other point I would add, though, is that people, and we sort of made this point back when Journal of Pain was the Pain Forum, and it was at some anniversary of the gate control theory, and the thesis that we put forward in that paper was that the gate control theory starts at the peripheral terminal. And that people talk about, and you conceive, and I'm willing to concede that analogy, that the gain control is really a CNS-specific phenomenon. But we know of a whole host of mechanisms, whether it be through the pituitary adrenal axis, whether it be through the sympathoadrenal axis, that the brain is influencing not just circuits within the CNS, but is influencing the periphery as well, whether it's the increased release of catechols, of opioids that are influencing the sensitivity of the peripheral terminals to stimuli, both pushing them towards excitability as well as moving them away from that it's bidirectional at the peripheral terminal as mediated by the brain as well. And so it isn't that the brain is simply influencing processing within the CNS. I think it's influencing processing out in the periphery as well.
And I think that's exactly how I explained Jordy's findings in fibromyalgia. That it's central disinhibition that he's seeing in microneurography.
At the terminal end. And I would argue that sleep is contributing in the same sort of mechanism, that sleep doesn't just influence CNS circuits. You can measure differences in transmitters in the bloodstream, depending on where you are in your sleep cycle, or if you're sleep deprived.
Okay, we have about 15 minutes. Questions for me or Michael, or something you want us to argue about? Mike.
I think a natural experiment that I was thinking about that kind of gets at this, at least it's a little bit simplistic, is that people, I think kids, with the SCN9A mutation, the 1.7 sodium channel deficit, I don't think they ever experience peripheral pain. Do they ever, is there a single case report that says that they have experienced some type of fibromyalgia or nociplastic pain?
Yeah, so I mean, I don't know if you could comment. I mean, what I would comment on that, and we were talking about this the other evening, which to me is an interesting thing. So these are kids that, if people don't know, the NAV 1.7 is a channel that has received a lot of attention from pharma as a therapeutic target for the treatment of pain, because there are human channelopathies, mutations in the channel that result in both a gain of function phenotype, that is, people that have pain syndromes, erythromelalgia, paroxysmal extreme pain disorder, are the gain of function manifestations that have been best characterized. And this insensitivity to pain on the other side, which would be, these are channels that basically have a loss of function. The interesting thing about those patients, particularly the loss of function patients, again, the two studies that primarily out of the same lab is John Wood, who's argued that loss of function phenotype is in part dependent on an upregulation of opioids in the sensory neurons, that if he gives naloxone to these patients, their sensitivity to stimuli changes. That is, that they now start to report the percept of higher intensity stimuli. What's interesting, in both of those papers, they don't describe it as pain. They describe it as an increased perception of intensity. And so what we were discussing the other night is whether the percept of pain requires a verbal construct. That is, that you need to actually have through your early life experiences. You stub your toe or you bang your knee and, oh, did you hurt yourself? That must be painful. That you're associating those experiences with the phenomena of pain, where these kids just may have never had it. And so they just might not have the terminology to use it. I hesitate to go too heavily on that particular model, particularly in light of MRI data to suggest that the pain matrix actually lights up in these individuals as well just fine, even though they're not perceiving it as pain, suggesting that the prediction with these mutations is that the nociceptors just aren't functioning the way they should, right? That they've got a population of neurons that are not encoding noxious stimuli, and the fact of the matter is that isn't what happened in these people.
To follow up a little bit, does that mean that pain is culturally influenced, or is it universal?
Certainly how we use the term is unequivocally culturally influenced. How we describe it. I mean, the only analogy, a sort of ancillary analogy I would bring, my father was a pulmonary physician, and just the different groups of patients that he would see that would describe basically chest tightening associated with asthma would be entirely culturally dependent, right? The words that we use to describe our experiences, whether it's shooting, lancinating, we have a guy at Penn who's trying to develop pain emation. I mean, I forget what his analogy is for it, but he wants images that people can use to better describe their experience because his argument is that the words don't go across cultures. And that we have a real problem in terms of treatment simply because, somebody comes in trying to describe a phenomena, and if they're using words that you don't know as a primary care provider, or as a care provider, it's a problem.
Sam?
Yeah, I think, so fantastic discussion, I really enjoyed it. It seems to me that with trying to understand the role or more definitively determine the role of ongoing peripheral input because of this enormous complexity of humans and our inabilities to get these deep assessments, that the animal models might be more useful here. And so I was trying to think about what are the animal models of widespread pain and what do they say? One that comes to mind for me is the John Levine model, where it seems like there's the increased catecholamine release from the adrenal medulla cause sensitization of the afferents throughout the animal in his upper dickball stress model. And so the two together, the increased catecholamines and cortisol levels that bathe these peripheral afferents and change the receiver operating curve characteristics is one example. But I was wondering if you guys could think of others and what the peripheral and central mechanisms of those are. And maybe that's more a question for Michael, but really for both you guys.
I'll tell you the two models that I think are I think the Julie's model is a nice model of nociplastic pain. I think the swim stress model is a nice model. And I also think the acidic saline injection on one side, contralateral Kathleen Sluka model has a lot of elements. I think that I like the naturalistic models of nociplastic pain that develop either because of a stimulus or because of separating them from their mother. Some of the ones that are more chemically induced I don't buy because I think you can't study mechanisms in a monoamine depletion model of fibromyalgia. So, but how would you answer that? What do you think are the?
To me, I think you can get to that phenotype in a number of different ways, and it supports sort of the basis for this discussion, right? That is, the folks in the migraine field are using it. If you inject inflammatory mediators on the dura, you can get allodynia in the hindpaw, which would be a pretty good manifestation of widespread pain. Is that what happens in most patients? Probably not. Are we adequately modeling what goes on? I'm not sure. Certainly, the data on early life trauma and its long-term sequelae, Julie's model in that context, some of the chronic overlapping pains combining injury and stress would come close. I think they provide or shed some light on it. It sort of is the naturalistic. It's sort of the descriptions that Dan has made of the patients that they're seeing. Whether it's Irene's imaging data, the imaging data that they're getting from the ABCD study that suggests that you have this brain change. On the one hand, it's predictive. On the other, I bring up the data on the migraineurs who clearly have altered brains, but aren't, by sort of traditional definitions, chronic pain patients. And so, I think we're still missing something there. Is fundamentally what my sense is, that even our models aren't quite getting the critical component of the pathology.
Yeah.
Thank you for the presentation. It's great. What can you say me about immunorelaxant for fibromyalgia? In Ukraine, we use per 10 days immunorelaxant, tizanidine maybe, and local injection for bupivacaine or Novocaine.
So for treating what? For treating fibromyalgia?
Yeah.
And what was the first thing I heard? Local injection. What was the first thing?
Yeah, 10 days for start. For treatment.
10 days of what? I'm sorry, I wasn't understanding the treatment.
So in the beginning of the treatment, during the first 10 days, when
We actually have a session with you guys later in the week where I'll talk a lot about the treatment of this kind of pain. So that probably is a better time because we'd have time to show slides and go through everything. So but the bottom line is that, you know, in general, we wouldn't be using like any kind of injection in a fibromyalgia patient. There's clinics that give lidocaine injections, but there's no data that that works, and I'm not sure that that's a good idea right now. So. Other questions? Bridget, you've been sitting there. So Bridget's a migraine expert. She's a neurologist who's a migraine expert. She's from the first K-12 cohort. She's at Mount Sinai. Do you have any comments about like migraine and central sensitization? Because I know what you have said is that just like this looking at your migraine patients through this different prism of like looking for chronic overlapping pain conditions, looking for nociplastic features was a bit of a clinical revelation. And I don't want to put words in your mouth, but I'm just sort of wondering what you think about the role of nociplastic pain central sensitization in migraine. There's a microphone right there if you want to.
So yes, I am a migraine specialist at Mount Sinai, and I also study the autonomic nervous system, and I'm one of the K-12 scholars from last year. And my project, which was initially just examining the autonomic nervous system in patients with episodic and chronic migraine, was really changed pretty dramatically after I learned about the presence of chronic overlapping pain conditions in patients with migraine, particularly chronic migraine. And I think one of the things that we're looking at is how patients with migraine and chronic overlapping pain conditions are really fundamentally different, right? So this idea of a moving threshold, I think, is really important. And I think it speaks to the idea of, you know, for some patients, peripherally mediated mechanisms are important, and for others, it's central. And the two can coexist, and one doesn't necessarily mean the other theory is wrong. It's just some patients have peripherally mediated migraine, and some have more central. And I think that what I see in the clinic, at least, is that, you know, a patient with a couple of migraines a month looks with a chronic overlapping pain condition like fibromyalgia, looks very different and responds very differently to treatment than someone who has chronic migraine, right? Which speaks to the idea of, I think, peripheral inputs, or the you know, experience of pain doesn't really matter where it's coming from, right? If it's coming from the knee versus the back, it's activating some final common pathways. And I think that recently, we've made some strides in the migraine field because insurance for a long time wouldn't cover Botox and these newer peripherally mediated therapies, the CGRP monoclonals, which, you know, they're working peripherally, right? They're not getting into the brain. These are giant molecules. And so patients would have to choose, right? Do I want a monoclonal or do I want Botox? And we have some great data recently coming out from Ronnie Bernstein's lab that these drugs should be used in combination, right? The Botox working on central sensitization should be used in combination with something like Emgality, which is a monoclonal antibody that's working peripherally. And the two, when used together, produce way better effects than when either one is used by itself. So I guess my question to you is, why is there a debate?
There's nothing better than ending a session with a really smart trainee. So we will just close this session now, and thanks to Michael for agreeing to do this. This was fun. So we have about a 15-minute break now.